Leo mentioned, I'm Danielle. I'm a product manager in Melbourne, Australia, and I work for a a large e-health and pharmacy solution vendor. I'm also an experienced designer, and I'm also a practicing pharmacist. So today, I want to talk to you about a big project that we've been working on in terms of making paperless scripts in Australia. And it's more around the complexities of designing for patient centricity. So when we talk about paperless prescriptions, a number of countries around the world already have paperless prescriptions and have had it for many years. But what's interesting about a lot of those implementations is that they're actually point to point. And I'm going to go through some of the complexities of designing so that the patient's in control and the patient has the freedom of choice when it comes to where they actually get their medicine supplies. So in our current world, pretty much every industry has already started to innovate or move towards a paperless interaction model for consumers. Their expectations are high. You can order food online, you can turn up at the airport and you can check in on your phone, you can check in on your smartphone, you can check in at a kiosk, you can order your tickets to the football online for yourself and friends, you can stream your TV and do everything through your phone. So for something that is seemingly so popular and so familiar, it's really interesting that in Australia, we haven't actually been able to achieve paperless prescriptions yet. Consumer expectations have changed, and when you actually go out and speak to patients and have a discussion with them, it's very confusing for them as to why they still need a physical piece of paper to actually get their medication supplied. In Australia, you still do actually need the physical paper prescription to get those medications. It's actually part of our legislation. But suddenly, after very slow moves towards digitizing across the health landscape, we've had a sudden move in the past couple of years towards actually accelerating our digital platform rollouts. Currently, nearly all doctors and pharmacies in Australia can actually transfer via what we call ETP. And there's two systems that provide electronic transfer of prescriptions in Australia. They're called ERX and Medisecure. When we talk about ETP, it's basically at the point of prescribing, they still print out the physical prescription, but there's now a barcode that's printed on that prescription. And that barcode is a unique identifier. And in the background, an electronic copy is uploaded to the exchange. So when the patient actually takes that paper prescription into their pharmacy, the pharmacist can then scan that prescription and download it directly into their dispensing software. So that was the first step, and that actually launched 11 years ago. The main part with that was that it actually did help with transcription errors. It also took away a lot of the arduous process for practitioners in terms of data entry, and it did see a large improvement in terms of compliance. But you still had to actually attend the pharmacy and hand over that physical paper prescription just to actually get your medicine supplied. So this is kind of what it looks like in the pharmacy today. So this is, I've taken these photos out in the actual pharmacy when I was working. For every prescription you hand over, there is a multitude of stickers that you have to print out, labels that go on boxes, claiming stickers that go back on the paper. And that's for every medication you actually process. Then if there's actually any repeats for that prescription, you then have to print out more paper. That paper is then attached to the original prescription. And that is what is actually handed to the patient to go and get their next supply. If you also want to keep the patients, so if the patient's worried about losing those prescriptions, because as you can imagine, if you're on even just three to five medications, that can become an awful lot of paperwork you've got to keep track of, and you need to have on you just so you can go pick up your month's supply. So one of the things we do in the pharmacy is we actually can keep those scripts or repeats on file. So now you've got drawers and drawers and drawers of just paper everywhere. And this is all about just being able to track what was actually supplied so that the government knows what they're actually paying for under our pharmaceutical benefit scheme. Then, even though the prescription's done, we then have to actually store that paper for an additional 7 years. So then you get boxes and boxes and boxes of paper that's then stored just in case you get audited. It's a bit of a logistical nightmare. The good thing is, at the beginning of last year, the government actually came out and they said that they were going to make paperless prescriptions a reality. The first step towards that, obviously, was changing the legislation. So as of November 2019, you can now legally transmit a paperless prescription in Australia, with the legal document being what's held in that prescription exchange service. So when a doctor uploads that script that's held in the exchange is the legal document, and then it's pulled down and dispensed in the pharmacy. So the legal document's actually held in the cloud. So we have the technology and we have the legislation. So why had we not still transmitted an electronic prescription? As I touched on, many models around the world, they're actually point to point. So if I go to a specific doctor in the UK or the US, that prescription is sent to a specific pharmacy. I don't get to choose which pharmacy I go to. In Australia, there is legislation that states that a patient has the right to choose where they get their medication supplied. So when they visit their GP and get a prescription, they can go to any of the 5,500 pharmacies in Australia to have that dispensed. And that's been a really important model that actually does enable a number of things that you don't get in a point-to-point system, which I'll touch on later. But even though it does have quite a lot of positives, actually designing for a patient-centric model brings about a lot of different challenges. All of a sudden, you've got multitude of actual stakeholders involved, but most importantly, you're trying to maintain the integrity of the patient-centric model, making sure the patient can have access to the medication, but then you have security, privacy, how do they show up and authenticate themselves to the pharmacist? What are you physically going to give the patient so that they can show as a token, for example, to actually get that prescription dispensed? So there was a lot of touch points in this project in terms of what we could design for and how we could best design those workflows for the actual patient and the clinicians without making their workflow much more difficult than it is today. The biggest impact is always going to be on workflow. So as soon as you start actually looking at any kind of workflow impacts for a clinician, you need to make sure that you are minimizing, because if anything is actually perceived as more difficult, if there's more clicks, if it's actually confusing, if they can't actually get through their workflow quickly and accurately, clinicians tend to have a big roadblock towards actually wanting to adopt those changes. So you also have to battle the change in adoption that they have as well. There's a lot of challenges in terms of that health ecosystem as well. So when we started to look at the different touch points in terms of visiting the general practitioner, visiting the pharmacy, what happens in hospital and aged care, there's a lot of complexities when we start talking about the legislation involved. In Australia, there is federal legislation, but each of our state or jurisdictions also have their own governing legislation around medication supply as well. There's also difficulties when we start talking about controlled drugs. So how do you make sure that you're providing electronic prescriptions, but you're not making it easier for fraudulent activity to occur around those controlled drugs? You need to make sure it's safer. So when we started looking at the actual design model, there was two basic models that really came into play when we started looking at how we could enable this. The other really important part of this was those systems are quite disparate. So when we start looking at the different technology and clinical systems that practitioners use, there was quite a lot of baggage that was around. In terms of how those systems actually communicate, you've got different technology, different platforms, different user experience. There's no standardization in terms of how that data is actually stored in those clinical systems. So transferring that data between the two is quite complicated, especially when you're actually wanting to put it up into a central system. So it sounds like a massive task. You've got this plan, you've got an end goal, but there's a lot of moving parts. There's a lot of different areas to tackle in the design, and there's a lot of different stakeholders to collaborate with. So the easiest thing to do was to break it down into the individual sections and tackle them one at a time. So the initial part was really understanding what it was that the user experience was going to be and how those workflows would play out. And that was done as a part of a technical working group across industry, the government, consumer, and clinician representatives. There was very early involvement, so we had to be clear with the requirements up front in terms of what it was that we were trying to deliver. So once we had the requirements agreed upon with everyone who was involved, the next part was to ensure that we actually could give them a visualization of how that actual workflow would play out. So we did a lot of lo-fi and hi-fi prototype walking through, especially with the clinicians, because they are the most risk-averse when you're starting to look at changing any kind of serious workflow. The best approach that we found was actually breaking it down into very small chunks. There's no point in trying to show them the whole goal and the end goal of the whole system if they struggle to actually visualize overall, and it becomes quite overwhelming. So they tend to focus on things that aren't necessarily the touch points that you really need feedback on. So by breaking it down into much smaller chunks or features, that basically we broke it into the two models and walked them through separately. That allowed us to get really good feedback quite quickly and iterate and go back to them through the prototyping process. The main goal, I think, is that in terms of having so many stakeholders involved, it is really important to ensure that you have at least some representation across all groups very early on. In terms of, there were some issues in the beginning of getting some consumer representatives in, but once we did actually get them on board, it was really good to have a separated voice outside of the health space that was contributing to the system as well. The other really important thing is when you are actually engaging with clinicians, you need to actually tackle those problems like they do health. When you actually have a patient come in, you don't try and actually solve everything in one go. You actually need to speak to the patient, break it down into the smallest chunks that you can, understand what the issues, underlying problems are that are going on. They then build a hypothesis, and that's when they start to diagnose. So if you can lead them through the actual design process and feedback process in a similar way to how they actually tackle their patients or how they approach their patients, you'll actually get a greater engagement, and you'll find that they actually start to understand a little bit easier than trying to actually look at the whole big solution at once. The other really important thing was understanding what factors are most important to a clinician in practice today, especially when you're starting to look at the design around the change and adoption. The system itself is one core component of design, but with anything like this, especially a nationwide rollout, you really need to look at how you can actually control the change and adoption, make sure that you're piloting, you're testing the system, you've got what you need in those small pilots, but then you can actually roll out across the country. You need to make sure that you've got a clear process and a way to actually train those practitioners on the changes, how it's going to impact their workflow, and actually get them to think about what they might need to change in their practices first. So the key things we found in terms of what actually matters is that they're really they're time poor. So you do tend to have quite a lot of patients. You don't have a lot of time. You want to make sure it's quality time that they're spending with their patient. If they're spending too much time in the actual system, clicking around, trying to actually figure out how they print a script, it's not going to be useful to them. There's also accuracy and making sure that the software is adaptive. You're never going to be able to actually design one workflow that works for everyone. So if you can put some flexibility into those design workflows, you'll get a greater encouragement and uptake. Understanding that there was a massive workflow impact on practitioners, we then had a look at where other industries had actually already tackled some of these issues. Because in Australia, we can't just cut over to paperless straight away. There's that rollout process. There's going to be a period of time where patients are going to be receiving paper scripts. They're going to start getting electronic tokens. So now in the pharmacy, you've got a multitude of workflows that are quite complex, particularly when I've got a patient that turns up, they've got a handwritten script from a specialist. They might have a printed script from the doctor that's got a barcode, and then they've now got an electronic token that they got from the hospital. So we actually went out and looked at industries that had done this quite well. And one of the big ones was McDonald's. In terms of when they actually did their technology changeover, they looked into a lot of different workflow process. So if a consumer comes into McDonald's, you can actually order via their phone app. You can order via the kiosk in store. You can order through Uber Eats. You can order through the drive-through. But the really important part of that process is no matter which way your order comes into that store, it's all channeled into the one omni-channel, which means it's then distributed to the right place to actually be prepared. So the order comes in, The burger part of your order goes off to the burger station. The fries part goes off to the fries station. But it all comes back together at the end when the order's ready and handed over to the customer. So they've got a really great way of leveraging technology to make sure that they create that single user experience for a customer, no matter which way they choose to engage. And we saw some really great ways that we could leverage those learnings back into how we needed to change and adapt the workflow models in pharmacy. Sorry. And similarly to when you actually go and check in for your flight, you can check in online, you can check in through a phone app, you can check in at the actual kiosk or when you get into the airport. But no matter which way you do it, you can still scan your actual ticket and board the plane. The other really interesting one we looked at was the ticket model. So in terms of the ticketing industry actually went quite early in terms of their online experience. But what we find is they've sort of gone early and sort of stopped with where they're at. So Tech's a really great example of they've gone in and they've actually done it so that you can get your tickets online and you're issued your SMS directly to your phone. And then you click on that URL and there's your QR code that you scan when you're actually going into the event. The interesting thing though is if you actually go and purchase 4 or 5 tickets for a family, so you're off to the football, you'll actually get 5 individual SMS. And when you click on each one of those, you've actually got to click in to see what the seat number is. So if you're forwarding that to friends, it can become quite complex and you might send the wrong one to the wrong person, or you might send the same seat to two different people. So whilst they have managed to improve that online experience, there are some limitations to how they've actually implemented that. I do have a video just sort of outlining how it works. My sound's working. Does not appear to be. Nope. Sorry. I'm sorry. The sound doesn't appear to be working, but basically this was a video that we actually created mainly just to give an overview to patients. So one of the big areas that we thought was really important was leading into rolling out the system is explaining what that change is, especially to patients, not just practitioners. So the idea of the video was just to give a really simple, high level and relational relationship to what they're doing today. So it sort of touched on that beginning part where they're already ordering, for example, on Uber Eats, or they're already actually using their phone app to engage online banking. So it was an introduction way to actually let them know, look, these are the kind of things you already do in other industries, and now you're going to be able to do it with your prescription as well. And so the main thing that came out of that was there's 2 models that we're actually going with. One is what we refer to as the token model, and one is what we refer to as the active script list. The idea with the token is you're essentially replacing that tangible piece of paper that you hand a patient today with an electronic token. So when you're at the doctor, they can actually, instead of hitting print, they'll hit send, and that's actually sent as an SMS to the patient's phone. That SMS, very similar to the Ticketek way, you click on the URI and you'll be able to see a QR code and some basic information about that prescription. The token was really important in terms of if you're going to take away the paper from a patient, that's what they've expected, that's what they've always got. Patients indicated that they really wanted to be able to actually receive something physical that they had to know that they had a script. So having that token was a way of letting them feel like they had some representation of what their script was when they turned up at the pharmacy, or they could forward it into the pharmacy. And that electronic token could be an SMS or an actual email. So that was all done and the design was ready to go, and we were working very slowly across the industry. Because it was such a big project, there's over about 80 vendors across prescribing, dispense and hospital that are involved in providing prescriptions in Australia. And so the plan around that was to actually, we'd got the design solved. We were working with the vendors to actually integrate and get that developed. And the idea was that in the middle of this year, we would actually start to pilot it, but we would pilot it in very small rural areas where we could actually test the software, test the exchange, make sure everything was working, there was no clinical issues, and then we would very slowly roll it out, applying the change in adoption, making sure patients were comfortable. But then the pandemic happened. And so since March in Australia, everything has been shut down like most of the world. There was a lot of isolation put in place. People, the WHO declared the global pandemic, borders were shut, stay-at-home orders were ordered, and non-essential business was essentially shut down. So as this all occurred, some questions started to arise in the government, and that was around, well, what happens to the supply chain? So what happens if we can't get deliveries where we need to? And what happens if there's medication shortages? How do you minimize contact with patients? Because at the moment, we required you to actually get your prescription from the doctor and walk it into the pharmacy to collect your medicines. So this became a bit of a complex issue in terms of, well, we've got this project, we've got this technology, how do we get that out quickly so that we can actually avoid and minimize these impacts that this might have? So the federal government actually announced that they were going to fast track the rollout of paperless prescriptions this year, and we were given 8 weeks to deliver it. That was 6 weeks ago. And so that's a massive task to actually work with that many vendors and try to actually get that system rolled out. We'd built most of it, but there was an awful lot of work we had to do in terms of some of the prescribing software, making sure it was all working end to end, getting it into an actual area to go live and actually test that for feedback. That would also mean we'd have to be quite agile in terms of how we worked with patient and clinician feedback when we did start to roll out, because it would be quite an aggressive rollout once we went live. The one piece of the puzzle around why this was fast-tracked, I think I touched on earlier, is that I know everyone says they're different, but in Australia, we really are different in that we do have that patient-centric model. And the importance of that patient-centric model did mean that we could actually we could actually minimize the risk of some of those issues that were a concern. So the out-of-stock medication, the what if my pharmacy doesn't deliver, what if the pharmacy is closed? In that point-to-point model, you don't have that choice. So there's a classic example in the US where the prescriber sends it to the nearest pharmacy, but you turn up and it's closed. So you've got to wait till tomorrow to pick up your medication. By having that patient-centric model, when the patient actually receives the token to their phone, suddenly they've got a greater access to be able to actually contact their local pharmacy. If that pharmacy doesn't have their medication, they can contact a different pharmacy. So it actually opened up a lot more options and meant that you could minimize the chance of adherence issues and delays in accessing those medicines. It also meant that if we had patients that were pushed into isolation or were required to go into quarantine, they didn't have to leave home because they could actually do a telehealth consult, have their prescription issued directly to their phone or email. They could then forward that to their local pharmacy or any pharmacy that has the meds. And from there, they could actually have it delivered back to their house. So all of a sudden, you've provided a safer, less contact, but making sure that that medication was going to be taken. So what does that look like? Basically, it provides a layer of security to frontline health workers. It actually did help a lot by minimizing the amount of traffic that you had in store and also minimizing the amount of unnecessary traffic at the clinics, but allowed the actual practitioners to still engage clinically from a remote setting. So the full online interaction that was actually put forward for the fast track was that the patient has a telehealth consult, as I mentioned. That prescriber issues the token to their script or phone, and then the patient could forward it to the pharmacy to have it delivered. What that looks like is on the left here, when the patient receives their actual token, that's the prescription on the left. We don't actually provide any clinically relevant information in terms of the patient's name, purely for privacy and security. There's also a URI for that prescription. When they tap on that actual URI, it loads their public web page. And in that web page, again, there's no actual patient or identifying information. We do give you the name of the drug so that you know which medication the token's for. We also tell you how many repeats are remaining, and there's that QR code. This QR code is just a script identifier. It's unique to this particular prescription and can only be used once. So once it's actually dispensed by a integrated software, that prescription is marked as dispensed and it cannot be dispensed again. The patient then just takes that into the pharmacy, or as I mentioned, they can actually forward it to a mobile number at the pharmacy. There is some workflow software that can receive that token remotely, or forward in the email, and the pharmacist can actually process that prescription. This is also, I touched on the workflow management software. In terms of in pharmacy, as I said, there's going to be multiple channels. So they've got paper prescriptions that are going to be coming in. They've got electronic tokens. The patient could be using a patient app to order their prescriptions. So all of a sudden, they've got these multitude of different ways that a patient might be bringing prescriptions into them. And the old way of using a physical basket with all that paper, that's just not going to be a manageable process in the pharmacy anymore. So we actually had to build a workflow management software to help pharmacies transition into this process. And it was modeled on the context, like I mentioned, around how the airline industry has tackled this problem and how McDonald's has tackled it in terms of that customer experience. So the workflow management software will receive those orders remotely. It receives it in store, and it basically puts it into a queue. That electronic queue is kind of like your electronic basket that you deal with your workflow today. And that allows them to distribute it to where they need. So once they've got those scripts in, that basket's created, it heads into the queue, which is their dispensing queue. It's prioritized for them. They can see when the patient's expecting to have it delivered or picked up. Once they've actually dispensed it and they can see the information on that prescription electronically that was required to be dispensed, they can then check it. So if you don't have a pharmacist actually processing the dispensing, but you do have someone checking, you have the ability then to check the prescription and the labeled medication, and then there's a process where it goes to out. It also allows for electronic notifications, so it can actually send an SMS or an email back to the patient to let them know their medication's ready or it's on its way and it's being delivered. So it's starting to enable a much greater customer experience, and kind of what the patients are actually already experiencing in multiple other industries. This was just a picture taken in the pharmacy. So the impacts of those workflow changes as well was that the pharmacist now needed to be able to see the physical information of the electronic script side by side when dispensing. That's another professional or legislative piece that has to occur in Australia. And at the moment, you've got the paper prescription in front of you to actually look at and check when dispensing. But when you go to an electronic script where the electronic legal document's now in the exchange, you don't actually have that physical document to check against. So the workflow software we built actually renders an electronic prescription similar to what they get in paper today. And rendering something that's similar to what they have today really can help with that change in adoption. So whilst we could have just displayed the prescription as standard text, by actually putting it into that image, we found pharmacists really did actually take to the change a lot quicker. And they actually did provide comfort because they were used to looking for certain data elements on that piece of paper, the prescription date, the doctor's name, the medication name. So it helped with clinical safety as well. So on the 6th of May, which was, I think, a week ago now, we actually did go live. So 5 weeks after the government announced the fast track, we did go live in a small coastal town in Victoria, and that was with a prescribing system, a dispensing system, and the prescription exchange service. That particular Surf Coast town was chosen because it does have the unique position of having one clinic and one pharmacy in that town. And during the lockdown, it was actually quite ideal in terms of, because of the restricted movement, you were less likely to have a patient from Anglesea, for example, on a day trip to Melbourne trying to get their prescription dispensed. So it allowed us to be able to do that kind of pilot and isolated testing without concerns of those tokens being taken somewhere else where it couldn't be dispensed. Because the important part of moving to paperless is once that prescription's issued as paperless, it can't actually be dispensed unless you have compliant software. So we had some limitations of we really needed to drive as many of those large vendors through compliance and getting them integrated as quickly as possible so that if a patient got a script, they definitely would be able to have it dispensed. So where we're at with that is we've gone live. That's been running for about a week and a half, 2 weeks, and that's been going fantastic. We have had some minor feedback, and we've made some changes quite quickly to the web page, for example, and some of the and worked with the vendors that were involved. But we've also been heavily working through getting the other vendors, so all the pharmacy software vendors in Australia, integrated. And so at the moment, we're about 50% of the way through that. And we're expected to have all of those pharmacy dispense vendors integrated by the end of the month. So the next steps with that is that we're planning to continue running these small trials just for the next, till the end of May, making sure that we can test different clinical system combinations, so different prescribing vendors with different dispense vendors, just to make sure we've got that end-to-end process really robust before the general rollout. And that general rollout is due to commence progressively across the country in June. So the government's goal was to have it rolled out to 80% of the country in that 8-week time frame. So that would put us just in line with that 8-week time. We're also currently building the other model that I touched on, which is the active script list. And the difference with the active script list is the token model is great for the average user. So if you get 1 or 2 medications a year, that's really great. But if you have 4 or 5 medications a month, you actually start to get a little bit more complexity, like I mentioned with Ticketek. So if I get 5 medications prescribed as a token, I get 5 SMS. I then take those in to get dispensed. I'm then going to get 5 repeats for that. Suddenly I've got a whole bunch of tokens on my phone I'm trying to deal with. So the idea of the active script list was to actually remove those tokens, but it was also driven towards those who may not be particularly technology savvy. And once the patient opts into the active script list, all their prescriptions will automatically go through to a script list in the cloud. So when they actually walk into the pharmacy, they present themselves, they give their ID or whatever it is that they need to do, and the pharmacist can then actually access that script list and dispense off it. So I don't need tokens anymore. Some great flexibility that comes out of that is, you know, if I go into state and I've forgotten my medication or I've run out, I don't have that complexity of having to go to the doctor, get a new prescription issued, and then going to the pharmacy. I can simply walk into the pharmacy, give them consent to view my active script list and dispense off it. So again, it's actually streamlining compliance. You're not having to juggle those tokens, but it gives a great digital way of making sure that all your scripts are there. It's purely an active script list, so what you can have supplied today, but it also serves as an information to a prescriber as well. If I walk into a new prescriber, they haven't actually seen me before or know what medications I'm on, they have the ability to then actually look up my active script list and they can see exactly what I'm actually taking. And that's everything I was talking about today.
So one question I had, Danielle, is that around the opioid problem that's currently happening globally.
Yeah.
At what stage do you guys control that? Or is it currently still work in progress? And also, well done on being able to deliver on such a short time frame, which is mandated by a government. I thought that's a fantastic achievement. So really, really well done on that.
Yeah.
But how do you guys sort of combat that? Or is it something that you've thought about? Or is it a process that you cross the bridge when you get there?
It's actually a really interesting question. So we actually tackled the opioid problem or real-time prescription monitoring before we tackled paperless prescriptions. So about 3 years ago, obviously, there are some extended values to having a centralized exchange. When you've got that point-to-point, but having an actual exchange in the middle means we've got that data in an exchange in the middle. And 90% of the country's prescriptions are actually processed through ERX Script Exchange, which is a product that I look after. And so a couple of years ago, the Victorian government actually wanted to tackle real-time prescription monitoring in terms of opioid crisis and overprescribing and various other doctor shopping issues. And they actually put out a tender for a system, and we actually went in and provided a solution which basically leveraged that data that we had in the exchange. So whilst the prescription data itself is held encrypted, under legislation that Victoria had, we could provide them that data And we basically built a real-time alerting system. So that data actually flows through to the product called SafeScript. And when those transactions run in, it runs through a business rule engine based on the patient, the prescriber, and the drug that's being supplied. And then a real-time alert is actually provided back to the practitioner's desktop. And so, for example, if I have a patient who is on opioids and they're on multiples, if they're taking more than the morphine equivalent dose of 100 milligrams, which is the threshold, then that will actually trigger a red alert back to the practitioner before they finish prescribing that script. So now the clinician actually has information about that before they're supplying the prescription. They can click through and actually view the monitored drug history for that patient and make a clinical decision around it. SafeScript was never designed to be something that tells you whether or not you can prescribe or dispense for a patient, but it provides fantastic information back to the clinician in real time that they don't see normally. Because as I mentioned, you have those siloed health systems. A GP at one clinic can't see what's been prescribed at another clinic, and SafeScript provides that portal to see the overview, prescribe, and dispense for that patient. So we've actually tackled that really well, and I think that was part of what led into providing a national system, which we're currently working on rolling out across all other jurisdictions in Australia. And then the paperless just fits in really nicely with it because you've got that real-time alerting, you've got that transactional information to the clinicians, and now you're taking away the ability for stolen script pads or fraudulent scripts because there's no paper to actually do that with.
Absolutely. That's fantastic. Okay, thank you for that. Thank you. Great presentation. Really enjoyed that. I'm just going to open the floor up. If there's anybody with some questions, if you could either, Danielle, I don't know if you have access to the chat, but there's, so if you can perhaps just look at that and see whether there's any questions.
There was one question about Tele Consults with GPs, which is actually a really interesting point. Again, I think, and a lot of this was driven by the COVID pandemic. Telehealth also was one of those things that was kind of a little hamstrung in Australia for quite some time. One part because of the paper, another part because there was reluctance in the change from practitioners, but also because there was reluctance, I think, in terms of enabling that process by the government. And so when the pandemic did hit, telehealth was one of the first things the government actually pushed for. So they provided support, they provided funding, which meant that GPs could now provide telehealth consults and have reimbursements for doing that. And so that's heavily driven an uptake in the general practitioner space as well.
Hi, can you hear me?
Yep.
Yeah. Yeah, so do you know of Amwell? It's a party in the US, and they have this whole workflow sorted out. So they do Tele Consults and video via the mobile phones.
Yep.
And then through the app, you can also do get a prescription. And even because in the US, I don't know the situation in Australia, but in the US they have let's say online pharmacies, so they deliver it at home.
Yeah, so we do have online pharmacies, but one of the roadblocks to, I guess, general uptake or use of that was the paper again. So if I wanted to get a prescription online, I still had to actually mail in my script to the online pharmacy to process afterwards. So there was a lot of general roadblocks there in terms of that paper was driving a lot of roadblocks in terms of moving forward with some of the digital health platforms. And so by actually removing the legislation of the paper, it's enabled a lot of other systems to progress forward, like telehealth and consults as well.
Yeah. So you're really like grappling the problem by the roots, so to say.
Yeah.
Really cool. Yeah. Do you still have the flying doctor service, by the way?
Yes, we do.
Exactly.
Okay. Is there anyone else who's got a question?
Yes.
Can I jump in with
Sorry.
Oh, you go.
Hello?
Yes. Sorry, I just wanted to ask from my side, have you got any recommendations with regards to giving some insights on how you were able to help change the legislation and bring the government on board with that? I know that these solutions are actually existing in many countries around the world, but like for example, South Africa, we are still wanting to move in that direction, but I think legislation is a very difficult thing when it comes to design. It's a hard one to actually move.
It is, and particularly in the health space, that kind of legislation takes a really long time to not only get the government on board with, but then actually push it through. So it wasn't an easy feat. It's been something that's been discussed and pushed around the industry for around about 10 years. But in terms of what really pushed it forward, I think there were some key factors around, as Theo pointed out, the actual opioid crisis was one of the big drivers. And what I mean by that is, with that particular issue emerging, there was some very keen people wanting to address or tackle that issue responsively, rather than waiting until it was too big of a problem. And so when that sort of when we started to roll that out, and there was really positive results to that, there was a lot of lead-on discussion from that of some other ways that you can minimize, not just by alerts to doctors, but if you actually remove the ability for fraudulent paper scripts and those other processes that lead into it. So part of removing the paper, I think, was a factor of there were other issues that they were wanting to tackle that it was influencing as well. But ultimately, it came down to what the actual government's position was at the time. And I think it is one of the key areas in terms of health, and digital health systems was a key area that Australia in general needed to tackle. So they just came to the right place at the right time.
Thank you for that. I do think that it is different for each country or governments, and I guess that one way to also go about it is actually rallying a bit of the practitioners to get on board with that as well, so we can have constructive conversations with our government.
That's right. The more areas of, that's true of anything, but particularly in design, and that comes back to your stakeholders. Anyone who has an interest can drive it from a different angle. So your consumer groups will drive it from a clinical safety and the ability to actually engage better with their practitioners. Your actual practitioners will drive it from a workflow management, improvement on accuracy and transcription errors. So there are a number of ways you can drive it. And if you get enough people coming at it from different angles, you'll find that everyone gets there in the end. And I do think that the pressure coming from multiple areas, it does really drive faster.
Agreed.
Thank you.
Thank you for that. So Marie unfortunately couldn't make it due to sort of other commitments. Is there anybody else before we sort of close the session that has a question?
Can I jump in? Just around the infrastructure you've talked about that's been set up to allow this digital sharing, do you think that will feed into other areas? So like my area of work is mental health, is around the list of medications the patient has, the list of medications the list of medications the GP has. Do you see this maybe leading into changes or innovations in that space as well?
It's a really interesting question. The prescription exchange itself the prescription exchange itself is governed only to allow at the moment the transfer of prescriptions. So if you think about it as a post office, the prescriber is actually issuing that prescription. It's encrypted before it actually gets up, and we can't actually see anything inside it until the dispenser actually pulls it down, and it's unencrypted at the pharmacy. Over the years, though, with patient consent, that data could actually be transferred to other systems for other processes. And an example was, I think you talked about the My Health record earlier. Data that actually comes into that prescription exchange can be forwarded onto the My Health record with patient consent. So there certainly are downstream. And the other one I touched on was SafeScript, which is the real-time prescription monitoring. Again, under legislation for Victoria, if you want a monitored drug prescribed in Victoria, that information has to flow through the exchange to SafeScript. So there is definitely ways that data can move forward. We can't actually provide that access. It has to either be via a legislative tool or by patient consent. So there are ways that that can occur. And we do have another product that actually provides medication management, which is called MedView. And the idea there is to provide different tools and applications to view those things like medication lists or doing a meds reconciliation and various other activities that you might want to do as a practitioner around that.
Okay. Thank you. Okay, thank you. Thank you so much for that, Danielle. Appreciate it. And I know it's pretty late with you. I don't know if you have your glass of wine already or if you're going to head straight to bed.
Oh, no, it's not too bad. I'm sure I can have a glass of wine.
Perfect. So what we want to do is we're already going to close the session. So if there's anybody that has any sort of closing comments or any closing questions. I know Anne had a question that she asked on chat, and I know there was quite a bit of interactions. So if anybody's got sort of feedback or like any sort of question they'd like to ask, it could be to any speaker or anyone, or just a general question, you have the floor.
Straight.
Oh, very good. Okay, perfect. I'm going to leave it there. Guys, thank you so much. Appreciate everyone's time for the last 2 days. It's been fantastic. The interaction's been great. All the recordings from the session will be made available on our Slack group. We also have a feedback form. Please, this is our inaugural. This is our very, very first sort of online event. I thought it was great. Speakers were fantastic. A huge round of applause to all of our speakers. Thank you so much from everyone, from Australia, from the UK, from Germany, everyone who's sort of added to the success. We do appreciate it.